All right, thank you guys for having me. I'm Elizabeth Lord. I'm orthopedic surgeon at UCLA, and I must say I've really learned so much from the people in this room and from this course itself, watching it online. So I'm basically going to take what I've learned from these masters and try to distill it down into some tips and tricks for MIS prone lateral with deformity. So in general, you've sort of got to start with who should actually be getting a lateral as part of deformity surgery. As Dr. Walker and some others have mentioned, you really have to actually meet these guidelines for minimally invasive surgery. Potentially, they're maybe just requesting it, and if they don't get it from me, they're going to go across the 405 and get it from Neil. They're frail. They need to limit blood loss. No excessive vertebral body rotation, as Dr. Walker mentioned. And then if you're going to L4-5, you need to make sure that you can really access that L4-5 disc space with the crest below the pedicle there. You have to have a reason to restore the anterior column height or maybe get fusion there. And then maybe, again, you want to stage it so you can assess whether or not that person also needs a laminectomy or whether or not the indirect is good enough. So for me, I really do like the MSDEF algorithm. It's easy to follow, and I think it's important to understand the patient-specific goals of what they're trying to get, especially in terms of minimally invasive, whether that's going to meet their goals or not. In terms of getting a prone lateral specifically, they're going to have to, one, meet these criteria for the minimally invasive surgery. Maybe they need a spondylolisthesis and you need a facetectomy or some type of reduction there. Again, frail or sick, so you really only want to do it in one stage. Or they have posterior hardware that requires some type of revision and you want to do it in one setting. Or again, you really want to get that optimal alignment and lordosis that you can really only get in that prone position. In terms of who should not be getting a prone lateral, I mean, I live in Los Angeles, so I have the privilege of rarely having to operate on BMI 50 patients. But for me, you know, my finger is only so long. And so this is something that I really like to be able to feel and palpate down to the spine to make sure it's safe, that I'm not wrapping anything into that into the dilator with me. So I really don't like to go, I mean, I think they max out sort of at 180, and when you're prone, it gets much bigger than that. So I really try to do BMI under 35, or if they have a large abdominal girth, I stay away from that in terms of prone. And then is it safe? We've had plenty of literature so far that others have gone through that basically mention that that point is moot. We have enough literature showing that things float away in the retroperitoneal space from the people in this room, so we know that we can get there. So in terms of actually planning these cases, one, I'm trying to decide, do they meet the criteria for minimally invasive surgery at all? And once they've ticked that, do I want to do lateral or prone? So if it's lateral, potentially if I'm going to do something staged, if I want to assess whether the indirect decompression has worked in terms of relieving their leg pain, or if they require an A-lift stage. So for me, if they are not meeting that criteria of having that 40 degrees between L4 and S1, in my hands, that's an A-lift. A minimally invasive T-lift at 5'1" is sort of not going to cut it for me. So those patients, I am doing either staged with that lateral A-lift, or I'm doing those open. Again, if they have a very large BMI or a high large abdomen, that's another case where, for me, I don't think that in my hands I can really reach deeply enough to safely get a corridor for my dilators. And then if there's sort of any questionable vascular or neurologic anatomy, I don't want to risk it prone. I don't have vascular in-house all the time where I am, so I don't want to get into trouble in a sense where I can't necessarily get more exposure in that prone position. So the prone cases are going to be these single stage cases. If the patient's requesting it one stage, if I don't need to do some sort of indirect decompression, there's no question of it. Or if, again, they need to do, I know I'm going to do a direct decompression, then that way I'll have access to it. Or if I need to revise the posterior hardware or do a reduction for spondylolisthesis. So I'm going to walk you through sort of a case that I did in my thought process at each point so that the learners can kind of follow along and then hopefully take some of the tips and tricks that I've learned over the years and take it to their own cases. So this woman is a 75-year-old who had severe mechanical back pain, very limited ambulation. She tried all the non-operative stuff, and it wasn't working. Her ODI was 36, so she was extremely disabled. Her past medical history was significant. She had a history of PE. Her osteoporosis was, real. She had a T-score of minus 2.6, but otherwise was neuro intact and wanted to get something done after years of non-operative management. So the first thing that I did was essentially assess her parameters. And looking at this, she didn't have a PI-LL mismatch. Her L4 to S1 was like 33, so pretty close. And she did have a significant deformity here. Looking at the L4-5 level in terms of can I get that, one, she didn't need a huge correction. from 4 to 1 because her segmental lordosis there was close to adequate. And 2, can I get there? Yes, because if you look at where the pedicle is, it's above that crest. So even though the disc space is potentially below it, as long as the pedicle is above it, I can usually get there. The second thing is to sort of assess, what levels need to be done. I don't believe I got a SPECT on this lady, but that's one way to sort of see where exactly are the pain generators. You do try to avoid that L5S1 if you need to. But in this case, in this patient specifically, her L5S1 had a lot of spondylosis, this huge osteophyte in the front, that facet questionably fused in the back. So initially, I was thinking of actually going to T10, but then if you look at the T9-10 disc space, that looks like a place that could generate some pain if you stop there. Another thing I always check are the Hounsfield units on my CT scan. So again, I'd had this lady T-score minus 2.6. I put her on 3 months of an anabolic agent. That's usually my minimum. And then I go back and reassess. And her CT scan, essentially her L1 was sort of the best looking one with the Hounsfield units of 120 there. So although I wouldn't call that optimal by any means, that was the best for her. So I thought that would be a good ending spot. And then the question is, what side are you going to go for? We've touched on this a little bit before. Although her concavity was on the right, and in terms of accessing, that's obviously the kind of radial arc that you'd like to go from in terms of access. When I looked at it, she had this sort of dorsal vessel there, and then also she had the plexus was kind of sort of covered the entire vertebral body. So I didn't feel like it had a great corridor there in terms of getting to the L3-4 specifically. So in that case, I decided to go on the left. So again, running her through the Ms-Def algorithm. She did not have a fused or rigid spine like we saw in the CT scan, maybe a couple facets, but there was vacuum disc at those levels. So you know that it's going to be flexible and that you can move it. SVA less than 6, yep. PT less than 25. No, she was doing some compensation, although she didn't have a big sagittal deformity. And then was her LLPI mismatch less than 30? Yes. So this is a class 2. This is something that we can do pretty reliably MIS without having to go across the 405. So again, in terms of planning, I think it's really important to have some sort of preoperative planning technique. It doesn't necessarily matter what software you use or the robot or this or that, but I think in your mind having conceptual framework of what you're trying to achieve, and then it also helps you understand what type of segmental lordosis you're trying to get at each level. And if you've got a level that, let's say, has arthrosed facets, maybe you're not going to get a 30-degree correction there, even if you do an ALL release. So it's important to kind of stepwise go through each level and be realistic about what you're going to do. So in terms of the case steps that I used, first one is I do make a midline incision. This is something I learned from Dr. Anand. The cosmesis is basically much nicer if they have one sort of skin incision on the midline as opposed to multiple poke holes on either side of it. And then a tip I learned from Dr. Uribe is putting that needle into one of the spinous processes before you do your spin. It's kind of subtle to see, but you can see it on, I put a shiny arrow there. So the reason to do that is essentially so you can check it while you're doing your spin to make sure that there's like a reference point. Because in this case, even though it looks like there's retractors there, the fascia is totally intact or you can't see any bone. And then what I do is when I have my steps for the case put up on the board so that everybody can see what we're doing, and then basically someone comes through and checks them off to make sure everyone understands the order that we're going in and what we're going to be doing. I use a navigated burr, and I put it exactly where I want the screw to go in. And so I kind of put it where I want, I go in, make a pilot hole for the pedicle, and then I have the navigation rep save it so that it's a track to find with the screw later. I also make a sort of a nice big entry point for it. It's not just a tiny poke hole, it's like sort of a crater there so that I can find it next. And then I just take one of these single step screws, a couple of different companies have it. They essentially have a little stylet that goes out through the screw head, and you can sort of use that, again, with the haptics and mechanical to find that little crater that you made. I do it on power to save myself, and I try to keep my arm, close to my body, but sometimes it gets up. And then one tip in particular for doing your S2AI screws, if you're going down to the pelvis, which again, if I'm going down to S1 and these old people and up to L2, I agree with what Vina said earlier. I think you've got to go down to the pelvis. So here, what I'll do is I'll save the ghost of where I put my S1 screw, and then you can see sort of where the tulip comes out, because often with MIS surgery, getting that S2AI screw to line up with your S1 can be really challenging. So if you save it ahead of time, you can sort of line it up. And usually, for me at least, I tend to put my S2AIs a little too medial, so I try to cheat a little bit lateral, and then that way it actually ends up in a straight line. For positioning, again, this is that patient where I still had to go on the convexity because of her psoas anatomy. So with these bolsters, you put them against the patient, and they do break it. It's not really like the spine. What they end up doing is actually just breaking the pelvis away and the ribs away, so it really gets you access to those two disc spaces. As you can see, it ends up not being as curved as it sort of looks. So at these higher levels, you're really not as worried about the lumbar plexus as you are down at the lower ones. So in this case, my upper level, like I said, was L1. So you can see here that I've put the retractor sort of posterior, and this to be a little posterior if I was at L4-5, but here at 1-2, it's generally fine. But then what you can see is that because of the ribs are sort of having this downward pressure there, even though my K-wire can get in there, I'm not able to actually get my retractor in there because the rib is sort of blocking it. So my retractor is actually going into the end plate here, which again in T-score minus 2.6, like not very promising. So what about the angled instruments? Can we get the angled instruments in there? Again, we've got this force this way. The angled instruments, either they sort of get into the disc space or they kind of go through the retractor then into the end plane. So that's also not a great solution here. If you sort of just endlessly push there, you can end up breaking a rib. So the solution is essentially to actually kind of paradoxically angle the retractor a little bit more, so you kind of sneak in under the rib. And then this way you're not really fighting it, you're sort of sneaking under it, and your trajectory is much more straightforward. And the angled instruments can also help with this. The same issue comes up at L4-5, where again, let's say you can even get that dilator kind of into the disc space, which is a nice way to anchor it like we talked about earlier. But again, once you've got your retractor in and you have to pull that dilator out, you don't necessarily have something kind of keeping it from shifting away. So the solution that I found for that is basically taking those shims, and some of these dilators have two shims, and kind of walking it in. So if you can see that, you kind of start up here, and then you angle and kind of mallet, and eventually it will find its way into the disc space. And so again, even with the table broken, your correction can be quite good. Here's an example of the cage going in. You've got initially this kind of coronal, this sort of this shift there, this scoliosis. And then as the cage goes in, you can see we go from a relatively curved to a relatively flat disc space. So in this case, here's kind of the end result. But don't forget, if you've got to go to S1, you really should not be leaving that empty. I'm not personally an OLIF person, although I wish I was. So that's, in my hands, this is going to be an MIS T-lift. So again, I have to be sure I'm not trying to get any correction here, because I'm not going to, if I'm trying to get correction at L5-S1, it's got to be an A-lift. It is the last thing I want to do is an MIS T-lift here. You do want to unbreak that table before passing the rods. That's something, again, that's on my little note sheet to make sure that the reps take care of that. That's their job. And then I put on my screws. Again, it's all headless screws. Pass the rods. It's kind of debatable if you're going to go from top to bottom or bottom to top. We can talk about that later, and Dr. Anand can weigh in as well. But again, it's pretty decent correction, especially coronally for these. These aren't my favorite for a big sagittal correction, but I think it's achievable and gets the patient out of the OR in one day without an ICU stay, without any blood transfusion. So thank you all for your time.
Hey, can I ask you a question? I really think about where to put the incisions too, and you were saying the up and down incision. Mm-hmm. I always make a transverse incision in the back at the little poke holes, just like we do in the cervical spine, and it heals a lot better than going up and down. So I do like a little transverse incision, just like in the cervical spine.
For one to pelvis?
No, well, just if I'm doing little poke holes to put the screws in, which I think think, it doesn't make a huge difference, but it kind of helps out.
No, Bill, I totally agree. I think if you're doing 1 or 2 levels, that's fine, and that's okay. When you start doing T10 to pelvis, I'm going to show a picture. I'm going to preserve the name for that later. And actually, it's from our famous LinkedIn journal. And I can show you some stuff. And seeing patients, it is horrible. Yeah. When you start making 20 poke holes from T10 to the pelvis, I mean, luckily our patients don't see it, but we see it. And that's the biggest reason I stopped. It didn't make any sense. And a midline just makes it nice and cosmetic. And skin incisions, I'll say it a million times, MIS is not the size of a skin incision.
Huh? You're good. Yeah, but Neil, the thing is, Neil,
by the way,
Neil, but this is like
a facelift. Yeah. Anyone ever seen a facelift? Yeah. It's one of the biggest incisions ever. I know this is live, so let it go out. It's got nothing to do with the skin. They're doing the entire face. And put
I know. But yeah, but I tell you something, Neil. You're right, but this is a problem. Also, doing the small incisions, there is a technique for that. Because you have to start, for example, the most proximal screws, you need to make your incision up, offset. The lower screw, you have to make one incision for 5, 1, and the pelvis. It's like this. T10, your incision is like an T8, and then you just go slow. When you have on the concave side, you have one incision can go to 2 or 3 levels. This is not like I just start throwing incision like a one of those passional crime. With a stab wound like this and whatever. You have to actually consciously design where each incision is coming, because the last thing that you wanted is like the incisions almost kissing each other with like a 3 millimeters in between, which it doesn't make sense, And the other thing, Neil, I was doing midline incision, subfascial, subcutaneous dissection and getting to the WLC. Is very good for the surgeon because at the end, you see the heads of the screws and almost everything. But then I was getting called from the rehab that this patient has a lot of seroma. So then I had to start putting sutures between the soft tissue and the fascia, and even like that, I was like, I cannot afford this. So that's what I started deciding to go back to the small incisions. I don't know, it's just a personal experience. I may be missing something because you've been doing it that way for many years with no problems, Maybe you can give us some tricks. I don't know how the other guys, Liz, you do separate incisions or one midline incision?
No, I'm doing one midline now.
Yeah.
I used to do this separate, but I think it's much more cosmetic, which people ask for, to have one midline incision. I think it heals better. And I do try to tack down, and then we're doing these flaps anyway with plastics, right? When you do like a big open deformity, like I'm essentially creating that same flap, so I'm putting a superfascial drain in there anyway. Yeah. So I leave that drain in, that's the last thing to take out. Got to go down to 20 cc's.
Okay. I mean, my last comment is, as great as we all think we are, these patients come back for surgery. Try planning an incision now in a revision. I can show you some of that. Honestly, that's what made me change. You do a midline, it's beautiful. You can go back and do whatever you want. You can go back in there, it's not a problem. And I did a lot of what you're saying, Juan. I went through that. I personally was offended by my own incisions when I saw it. When I looked at that, it looked terrible. I said, "What are we doing here? It didn't make sense to me." And
the problem is you want to make them look good. It takes time.
Be good.
I don't know. The fellows see how much time is spending like planning the incisions on the skin. I like to be also symmetric. I don't like one incision like the robot. You see how the Globus robot? I mean, not Globus. Any robot that the incision, they put the two and you just go and pushes whatever, and at the end, incisions are like this, like that. It looks like a maze, I think I always joke with the residents and the fellows because I say that I'm a plastic surgeon of the spine because I plan all these things like a symmetric, perfect. The screws, I like them, when you distract it and compressing, they look the same. I don't like the heads, one polyaxial head like this and the other one like that. I want them but that's craftsmanship, So anyway, Liz, that's an amazing talk. No, thanks very much. And
let me ask you a question.
Yes, sir. To you, Liz. There you go.
Sorry. Yeah, just a little more important than how cosmetic.
Now where you're going with the
Hey, ready.
A Brazilian guy,
Brazilian, come on.
a Brazilian guy saying the cosmetic
Brazil or-
doesn't matter.
In Brazil
Doesn't
or
fit
in
in
San
here.
Diego, cosmetics is important. But
For how long you been living in U.S., Pimenta? Because you,
now
you
I'm
don't look
living
like a
in
Brazilian
US.
anymore. With
But still,
cosmetic,
San
it's
Diego
actually
is
everything.
fancy. Anyway, a question more important. You mentioned your limit in big patients, and I want to address a little bit and then have your opinion about that, because he has much bigger patients. And I use 6.5 gloves. So I also have short fingers, and the point is different. So big patients, big retroperitoneal space first, right? So you have the safety that the big patients, they have more fat. It's safer to go to the psoas muscle. But I agree with you. I feel much more doing better work if I can touch the psoas. The only way that you can touch the psoas in lateral is that you move the skin close to the quadratus. We saw talk first saying that you should start close to the quadratus and then find another spot to drive your dilators. So then you can also help the patients with bigger BMI.
Yeah, that's a great point. Another thing, actually, it's not open, but essentially open midline gives you access to is essentially if you do want to feel the TP, it's right there for you, so you can actually feel it without essentially just having a poke hole for the little screw. You can put your finger on the TP, feel that quadratus, and then potentially use that to kind of guide your dilator in. But to that point, I do like to have my it didn't somehow make it in here, but I always have my fingers ventral. Whenever I'm introducing a dilator, another dilator, I try to keep my fingers to not pinch anything in there until that dilator is in there.
So a quick question, how did you attach your extenders? After I saw they were headless screws, but then the extenders went on after.
The model.
Yeah.
So how do you attach that?
They're towers attached
So
to
easy.
heads.
I
Yeah,
know, but then you have to open the paraspinal space then. How
No.
do you go
No,
down?
you just
No.
capture them. It's
Can you
so
see
easy.
it? You can see
You
the
don't
screw
need to
head?
see
No,
them.
you
You
palpate.
feel it. You don't need to see them. You feel
On the
it.
modular screws, the insertion
It's
handle,
the easiest thing.
it creates a little track through the tissue that stays fairly consistent. So even if you come back later on,
So you feel the screw and pop it on?
You feel, and it's so easy. You put your tower and whatever it is feels harder, you're there, and then you just pop it up. You know, I think it's and the beauty is that you don't have these towers in your way all the case, which are annoying. You know.
I don't know.
I do everything modular nowadays, to be honest. I adopted 100% the modular screw. The only screw that I put with the tower is the last screws that I put, because then I don't need,
I mean, all I'd say, these cases probably, yeah, as you get a bigger deformities, that's going to be very, very hard. They crowd into you. It's very
Yeah,
hard to get
they
that
become a
extended down
maze.
there. So
Become
that's
a
what I'm
maze.
looking at. I think these cases, yeah, I can see you can feel it and pop it. Especially you got a deep lordosis way down there, and they're crowding into you and rotated. So it's really hard to pop that
It's
in.
good, and there's a technique. When you put modular screws, you cannot advance too much. You just barely pass the pedicle, so you still have the shank. You cap it, and then you go with the T-handle. You don't assemble again the screwdriver. And the trick is, you get the T-handle, and you move with your fingers, because if you force it, you change the trajectory of the screw, then you lose everything, So you have to be like this and advance it. It's actually a good technique. I think Liz probably we do is very similar, correct?
Yeah, exactly. You can't bury it too deep, especially with those big facets, the hypertrophic facets. You got to leave that proud, otherwise you'll never get the tulip on.
Yeah, that's awesome. And then, no, thanks very much, Liz. We're gonna keep moving to the lab. We have the greatest Tony Kwon, so you're